Welcome everyone, and thank you for those of you who are able to join us live and for those listening in afterwards. I'd like to warmly welcome our guests today, Pharmacy Heroes, who I will be introducing to you shortly. My name is Valerie Nolt, and I will be one of the two moderators for this webinar this morning as the webinar co-chair of the hospital pharmacy section. FIP's vision is a world where everyone benefits from access to safe, effective, and quality and affordable medicines and health technologies. The mission is to support global health by enabling the advancement of pharmaceutical practice, sciences, and education. We're pleased to be delivering this event, the 19th one in the Responding to the Pandemic Together series. Today is a special episode sponsored by the FIP Hospital Pharmacy section. COVID-19 has changed the way in which hospitals and health systems are operating due to an influx of critically ill patients, postponing non-emergent medicine care, and continuing to serve the medical needs of the population. The focus of this webinar will be to identify current examples of how hospitals and health systems are altering their practice models to meet those needs. In addition to myself, John Hertig, who is the Vice Chair of Pharmacy Practice at Butler University College of Pharmacy and Health Sciences, will be co-moderating this session. The webinars in the Responding to the Pandemic series aim to provide relevant information about COVID, share and discuss strategies that have been adopted, develop area-specific implications, engage the frontline workers, and discuss implications of this pandemic on issues across the world. And for this episode in particular, we will be focusing on hospital pharmacy. If you have additional ideas on webinar topics that we should feature in the future, please feel free to share your story with Lena at FIP.org. FIP also has created an information hub and Facebook page in which users are able to interact more with the COVID-19 content. And please note that this event will be recorded, live streamed on Facebook profile, and is freely available. To all those who are listening, please make sure that you're typing questions in the Q&A box so that our panelists are able to address those and follow up as needed. And as always, we definitely welcome feedback on the webinar this morning. Our learning objectives are to identify problems facing hospitals and health systems during this COVID-19 pandemic and relate the personal experiences of the panelists that we have with us this morning to discuss ways that pharmacists and pharmacy departments can continue to collaborate to provide patient care. This morning, I will be introducing our panelists. Our first panelist is Adenji Manuel. He is the Assistant Director of Pharmaceutical Services at Jos University Teaching Hospital in Nigeria. Anna Herranz is our speaker and panelist number 2. She is a hospital pharmacist operations manager at Hospital Universitario Gregorio Marañón in Spain. And our speaker and panelist number 3 is Dr. Michael Ganio, Senior Director of Pharmacy Practice and Quality at the American Society of Health System Pharmacists in the United States of America. And last but not least, our fourth panelist this morning is Nai Huai Mei, Clinical Pharmacist Specialist at Shinkong Wu Hosu Memorial Hospital in Taipei City, Taiwan. So without further ado, I will be turning it over to John to begin our conversation about responding to the pandemic together.
Thank you, Valerie, and welcome everyone on the webinar today. We're just so pleased that you're joining us during such a critical time, and pharmacists do play a really important role in managing the COVID-19 pandemic. As a way to orient you all to our program, the World Health Organization emphasizes the need to, quote, focus on securing the global supply chain, which is clearly a pharmacist's role. Really, pharmacists should be involved in any process or any activity that includes medications. And in light of COVID-19, is it possible to really support strong quality assurance principles? And I think that's the question we're hoping to try to answer today in terms of high-use medications, managing inventory supply, working on a number of drug shortages, dealing with foreign medications that constantly change and shift, as well as securing national stockpiles to take care of our population. And so this represents the first topic area that we want to cover and really get the insight our panelists, and I have a number of questions to ask, and we'll jump right into it because we do have a packed program today. So with drug procurement in mind, I want to ask our panelists, how are drug shortages and personnel protective equipment shortages being managed in your jurisdiction, in your country? Can you give us some insight on how you're able to keep that supply going?
Hi, John. This is Mike from ASHP in the United States, and I'll actually start with a little bit of background to set the stage on what our hospitals we're dealing with. ASHP sent out a series of surveys, and what you see on the slide here is a snapshot of some of the results from our 5th round of the survey. And what we wanted to know was the status of some of these drugs and of personal protective equipment. And what we found is particularly drugs required to treat patients who are on ventilators. So sedatives, neuromuscular blocking drugs, some other supportive medications like albuterol meter dose inhalers were in short supply in the United States. And then we also asked about personal protective equipment, standard surgical type masks, N95 respirators. And what we found is that early on in the pandemic, people hadn't yet been hit by the shortages. We started our survey data early on. But as things progressed, the surgical masks, the clean room equipment, so beyond PPE, things like sterile isopropyl alcohol that we use to clean engineering controls where we prepare sterile products, were all becoming short supply. And the unique thing about these shortages, typically when we experience shortages, there's some sort of quality problem on the supply side. So there's a recall, there's an impurity in a product, there's glass particulate in a sterile injectable, and that means that we have a hard time acquiring the supply. In this case, and the United States distribution model may be unique, but in this case, it was a surge, an unprecedented surge in demand that made it very difficult to acquire some of these drugs in areas that were very hard hit. And our international attendees may be aware that about 2 months ago, New York City was our epicenter here in the United States. And those hospitals really were challenged with finding these drugs. So I'll stop there as sort of a backdrop of what we were experiencing in the United States, at least. I have some responses of how these were handled, but I'll let our international participants share their experiences as well.
In Spain, I first want to thank FIP for inviting me to this seminar. It's really exciting sharing COVID pandemic experience of my hospital, because I think this pandemic has joined all the pharmacists together. We have shared a lot of protocols and different resources that make us respond quicker. So in our case, in Spain, if you put the slide, I have to help. Valerie, if you can put my slide, please. In Madrid, this is how the patients came to my hospital. So if you see here, in 20 days, we got close over 1,000 patients. So this made a change the way we buy the drugs and we acquire the drugs. We have, in Spain, we have par levels, so we order directly to the pharmaceutical companies. And at the beginning, everything started doing that. We had the stockpiles in our hospitals, and only for drugs that were specific for COVID treatment, like tocilizumab, were distributed by the Spanish Agency of Medicine and Medical Devices. So we had a platform that we ordered these drugs individually by patient, depending on the clinical conditions, on the moment, and different clinical levels. But then when the shortage came, when the yellow that are intensive care unit patients increased, they came the shortages that Michael were talking before. So it's kind of the same situation. So what the authorities in Spain did, we had a regional distribution of drugs based on intensive care unit patients. So it depending on the number of patients we had in the intensive care units is how the pharmaceutical companies give us the drugs. So I think this is complement to your vision, Michael.
First of all, hello everybody, and I'm Naihua Mei from Taiwan. And to add on to that, kind of how we managed when it came to drug shortages. So I think the best example and the first thing that kind of pops into my mind is the use of hydroxychloroquine. So during that time period where there's still no vaccine and there isn't really an FDA approved agent and large enough clinical trials to fully support our assumptions. So when faced with these mild and severe COVID-19 patients, we kind of took the route of giving them this three-way drug combination that consists of hydroxychloroquine 200 milligrams twice per day, and azithromycin 500 milligrams once per day, and zinc sulfate 200 milligrams once per day. And that was published through the NYU Grossman School of Medicine, and it seemed to be the most promising at that time. So kind of with that in mind, beforehand, we looked into, as a pharmacy, we looked into our inventory. And as of February 8th, we had around 3,000 tablets of hydroxychloroquine. And using our computer system to kind of track back and look at the usage when it comes to in and out patients, I would say we use around 1,500 tablets on a monthly basis. So what we kind of did was we purchased an extra month of supplies to be better prepared in the case of a sudden influx of patients. And we looked at how many beds we had in Xinguang Hospital. So we have more than 833 beds and 11 isolation rooms. So assuming that these negatively pressurized rooms were all occupied by COVID-19 patients, and they all had to be under this 5-day regimen at the same time, we should have more than enough stock. And luckily, that's exactly what happened, and we didn't really have an issue of drug shortage. However, I did get the opportunity to kind of discuss and talk to other pharmacists from other hospitals. And early on, they kind of noticed patients kind of coming to the hospital and paying out of pocket to obtain these medications. And that's kind of our main concern, because we keep on emphasizing how hydroxychloroquine, azithromycin, these type of medications should be taken under the supervision of healthcare professionals and not used as self-medication at home. So what they did was they actually put a lock on their computer system. So they limited to certain specific physicians under specific departments who could actually prescribe hydroxychloroquine. And when it came to azithromycin, they actually put a limit on the amount of days you could prescribe it as well. So these are just a few actions as pharmacists we took within the hospital to ensure public safety and to prevent issues such as drug shortage. And all in all, it really just comes down to being prepared and knowing where to get your resources and acting upon that plan.
Thank you all. Any other comments from the panelists on managing drug shortages before we move on to another question?
This is Mike. I would just like to say what May outlined as a response to shortages is a really good plan. When you recognize that a drug is going to be in short supply, taking inventory of what you have on hand, looking at your utilization, how your hospital is using it, understanding how long that supply will last, is a really important first step. From there, you can start to look for therapeutic alternatives if needed. You may decide to consolidate your inventory into a central area so that you can control the inventory better. You may, in the case of some of these drugs that are sterile injectable products, you may decide to do all the preparation in one place, and that way you can if there are single dose vials, where if it's prepared at a patient bedside, the remaining amount in that vial should be wasted. In a pharmacy, we can continue to use that vial under United States Pharmacopoeia standards. So really finding ways operationally to conserve your supply, and then clinically to understand what your alternatives are and what are the pros and cons of those alternatives. So what May outlined is a very sound strategy, and it's what we see in a lot of our hospitals here in the United States.
Okay, well, thank you all for your response to that question. I'd like to move on to another question. In your jurisdictions or countries, how are national stockpiles of medications and supplies being utilized and distributed? And I know we've touched on that already a little bit with the previous question, but perhaps you can give us more insight into how your current supply is being utilized and then effectively distributed to those who need it most.
I guess I'll go first again. In the United States, our stockpile is really designed for an emergency. The drugs are spread out throughout the country, and it's intended really for the first 24 hours of an emergency, whether it's a biologic attack, a chemical attack. It's not really designed for this sort of pandemic. So while there are some antibiotics in the stockpile, it's not really these emergency medications that we're in short supply, these medications that we need for patients on ventilators. What we did do with our stockpile here in the United States is the addition of hydroxychloroquine through doses that were provided to the United States government. And those were dispensed out to hospitals where they were being used on COVID patients. But our national stockpile, for drugs at least, really did not come into play during the pandemic. We do have some medical devices, some masks, some N95 respirators are in the stockpile, and those were distributed. But from a drug perspective, it's really not intended for this sort of pandemic.
When it comes to national stockpiles of supplies, I would like to point out what an outstanding and an excellent job the Taiwanese government has actually done when it comes to ensuring easy access and availability for all citizens during the pandemic. I would say this comes from past experience. So if we go back into 2003, during the severe acute respiratory syndrome epidemic, we also saw a surge of demand for personal protective equipment, and that included surgical masks. So as a must need, to help flatten the curve and kind of raise the line. And also not to mention, we kind of see this phase of the public panic buying. So when it came to surgical masks, hand sanitizers, and even toilet paper, in which up until this point, I still don't quite fully understand why there was a shortage. But the government, the Taiwanese government this time around was able to, with that past experience, act promptly and effectively on implementing policies that would greater strengthen our quarantine measures. And that would include enforcing the need to wear masks in public, when you're boarding public transportation, going to restaurants or stores. And all arrivals must submit to a 14-day self-quarantine. And the government promoted social distancing and disease awareness through press conferences and pamphlets. And basically those who did not abide by the law would receive a fine. So to go into more detail about PPE, our government actually imposed a ban on surgical mask exports around late January, I would say. So by the time February, we had this rationing system that was established, and we scaled up our production. So by the time of April, you're looking at Taiwan producing around 13 to 17 million masks on a daily basis. and that's for a population of around 23.8 million. So it's kind of like around a 2-week time span, and the public was able to get 10 masks on average. And that's why Taiwan has been able to provide surgical masks for the public, and also not only donate more than 7 million masks to countries who have been severely impacted by the disease. So at the end of the day, I think our strategies have shown to be effective, and that's why we have a relatively low number of confirmed COVID-19 cases. As of date, it's 446 confirmed cases, and 435 have recovered, and with 7 deaths as of date. And if you look into it, it's mainly imported rather than locally acquired cases.
In Spain, we have also better stockpiles programming in drugs than in protective equipment material. So we had suffered a lot with these masks and all the devices needed for protected people. And really the stockpile for medicines was not according to the pandemic at the beginning, because we are ready for other kind of crisis, but it's the first time we suffer a crisis like that. So we are improving the stockpile, and regulation is coming out these days back to improve for the next crisis like that.
Again, thank you for sharing your insights. Are there any other comments from the panelists? Okay, all right. Well, I really appreciate it. I think we will move on to the next category, and for that, I'll turn it back over to Valerie.
Great, thank you. So one of the difficulties during this pandemic has been changes in how we actually prescribe and validate prescriptions due to the potential of not being able to have face-to-face interactions all of the time with the healthcare team. And in some instances, the pharmacist is included in the healthcare team and the decision-making process. And sometimes the pharmacist is not necessarily a part of the specific healthcare team or the decision-making process due to some sort of constraint. And so our first question for the panelists is, how has healthcare information technology been implemented for decision support and caring for patients with COVID-19?
I'd be happy to start first. When it comes to Taiwan, just some basic background information. We have everybody's covered by the national healthcare system. So with that, we have this national health insurance card that once is passed through our computer system, allows healthcare professionals to access the patient's prescription, examination, and treatment records over the previous 3 to 6 months. Most importantly, we've had this new function integrated into our NHI cards, where once passed through, we can see the patient's history of travel or transit in affected countries or areas within 30 days. And that includes transfer flights from China, Hong Kong, and Macau. And with this essential information, we're then able to use it as reference for the physicians to kind of treat patients and prevent duplicate prescriptions and examinations. And as a pharmacist, we are then able to practice medication reconciliation to better understand the patient's medical history, medication compliance in general, and become more aware of their underlying comorbidities, whether that be hypertension or diabetes mellitus, which have shown to increase mortality in COVID-19 patients. Let us not forget preventing adverse events due to drug-drug interactions. But that being said, whether it's caring for COVID-19 patients or not, this is a form of standard care that we regularly practice in our hospital. And it is with this form of healthcare IT that has allowed us to kind of safeguard the patient safety and improve healthcare quality, and most importantly, reduce medical waste.
Thank you, May, for sharing those insights. Adenji Manuel, you would like to offer us some perspective as well?
Should I complain to them? Or should I discount? What if
Adenji, we're having a little bit of difficulty with your
should I
sound.
off this one?
Are you able to speak to how healthcare information technology has been
How do I
implemented?
disconnect this one? The Bluetooth. Disconnect.
There we go. We can hear you if you're able to speak loudly and clearly. Okay, we'll try to come back in a second if Anna or Mike has anything they'd like to say about this.
Yeah, we have a similar situation, but from a more hospital perspective. Our clinical decision support system was fed by pharmacists with all the information needed for drug-drug interactions, protocols, and update the information really quick, because one part of the essential role of the pharmacist here related to patient safety is that the doctors that prescribe were not always as senior as we expect. So, and doctors move from one section to other section. At one point, our hospital was a complete COVID hospital. So having the system update really fast and really with this, all this help, improve patient safety, and also did a very good job in rising pharmacist work in the hospital, not doctors that are really not used to prescribe to internal medicine patients, or anesthesiologists that help in the intensive care unit. They really came to the pharmacy and say, thank God we had the protocols and we have all this help and drug-drug interactions, and all these checks in the pharmacy help a lot.
Among our members in the United States, the healthcare information technology that really was beneficial has been remote and telehealth visits. We've had some adoption of telehealth over the last several years, but until the COVID pandemic, it really it required healthcare systems and payers to recognize that as a form of interaction with patients. And the same thing with physicians and other providers meeting with patients remotely over smart devices or smartphones. Our pharmacists also worked remotely, so keeping pharmacists out of the hospital, away from patients when needed to keep them safe was one of the strategies used to leverage healthcare information technology. We also saw increase in electronic e-health visits between pharmacists and patients. In the United States, we have pharmacists who will manage patient chronic conditions, manage anticoagulation, diabetes therapies. The use of telehealth technology allowed our patients and our pharmacists to continue to work together to improve the health of our patients without increasing the risk of exposure to COVID.
Wonderful, thank you for sharing. Yes, it's definitely been amazing to see what we've been able to do with technology and the ability to still interact with patients and healthcare providers, even if we're not directly in the same room with them. So Adenji Manuel, were you able to join us with your sound? Okay, it looks like we're still.
Thank you very much. Yeah, can you hear me now?
Yes.
Okay, thank you very much. With regards to prescribing and validation of prescriptions, pharmacists are part of this team, and we rely on pharmacopoeia. We rely on the guidelines set by the Nigerian Center for Disease Control on the medications that we are supposed to use for our patients. We make use of phone, making telephone contact with our patients, and we also use the social media like WhatsApp and others to communicate information with our patients. Thank you.
Thank you for sharing that. Yes, it's definitely been interesting to see the rise in the use of social media in order to be able to translate information in a quick manner to a wide audience. So our next question for this section is, how are policies, protocols, and guidelines related to COVID-19 being updated in an expeditious manner? And Anna, I think I will start with you and go ahead and put up the slides that you had helped us create.
Thank you. I think updating drug selection and protocols has been one of the main roles of the pharmacy team within the hospital. You know, in the hospital we had a crisis team, but we have, because we didn't know exactly, and we still have some questions about what is the right treatment for those patients. So the protocols experts group was really very important in the hospital during this time. This was a multidisciplinary team. I think this pandemic has really done a lot for multidisciplinary teams. I think we've been working together with other doctors from different specialists and infectious disease, internists, pharmacists, pneumologists, intensive care unit doctors, cardiologists, and really we had a multidisciplinary approach to the disease. In our hospital, we had more than 18 reviews of the protocol, so this is a really very fast update of the protocols. So this is we don't have any precedent like for that. No, it's one of the main differences in these protocols. We have an approach on the antiviral treatment, corticoids, immunomodulators, and advanced therapies. We are using immune plans in some patients, but the protocols were really complete about other gases, ventilators, anticoagulation, and thromboprophylaxis. Also, we have a part of monitoring drug adverse events, what was really important from safety perspective. And especially I put in the slide the drug-induced arrhythmias by the COVID drugs or the hyperglycemia induced by the corticoids. So it was a very complete protocol, really review very fast. I think we have a lot of open resources from journals, and also it was the first crisis where the social media did a lot of confusion with the information that we got in the hospital. So I think having the protocols, the protocol expert group well set in the hospital is one of the key for succeed.
Excellent, thank you for sharing. And then you had also talked to us about some of your prescription support as well.
Yeah, that I mentioned before, as the protocols came out, we put that in real-time incorporation to our CPOE system. And it was very fast with the clinical alerts and protocols and to guide early selection of treatment for patient safety. And we increased the resources for 7 days a week for pharmacy order review. And also a very important activity that we did was patient discharge education, using maybe telemedicine or using different supports to keep people safe away from the virus, but really patients having the right information when they were discharged was a good point, because sometimes we didn't have only a lot of patients went home as fast as we could, no? So I think this was also an activity that took us a lot of time, and we really think we added value here, a lot of value.
Excellent, thank you. May, would you maybe be able to share how you have been able to implement changes to any policies, protocols, and guidelines in an expeditious manner?
Yes, of course. On a governmental level, we actually, they formed the Central Epidemic Command Center, short for CECC, and it was established on January 20th, 2020. And not too long after that, we had our first COVID-19 case confirmed. And so what the government did was it provided us with the latest information through multiple channels, and that being releasing news reports or holding daily press conferences depending on the extent of the epidemic, to notify the public of the current situation and the tackling strategies. So they even tracked public opinion continuously and proactively responded or clarified when necessary to avoid any kind of misunderstanding or panic among the general public. This constant kind of communication strategy to ensure the correct information is distributed in a timely manner is especially worthy of praise. Hospital-wise, our supervisors conducted daily to weekly meetings and to establish policies in regards to the latest announcements from Taiwan Center for Disease Control. And any updates or confirmed protocols would then be passed down to us through official documentations and our email. So it's more of a top-down approach and done in a very timely fashion.
Excellent, thank you. And then Mike, you had mentioned AJHP, the American Journal of Health System Pharmacy, has an assessment of evidence resources that are available?
That's correct. So in the United States, ASHP is responsible for an AHFS drug information. It's a big red book, and we have a team of drug information experts. And what they've been doing is compiling the evidence for all of these drugs that are being trialed for COVID-19, whether hydroxychloroquine or remdesivir, famotidine, a lot of drugs that have been in studies, and what we've done is consolidated that, put it in one resource. I think one thing that Anna said that's very important is understanding that information is coming out very quickly. This is a brand new illness. We don't have a lot of experience with it. We're gaining experience. We are slowly getting real strong evidence in the form of randomized controlled trials. But as evidence is coming out, whether it's case reports or or those randomized controlled trials evidence,
Mike, I think we might have lost your sound just a little bit there at the end.
Oh, I'm sorry. Can you still hear me?
Still a little bit soft. So we'll go ahead and move on to the next section where John's going to take back over and talk about preparation, delivery, and administration, and we'll test out your sound when we get to that.
Thank you, Valerie. Now we're on to the all-important section of preparation, delivery, and administration of medications. And there are lots of different topics that we can cover in this section, including potential staffing changes that you have had to make at your facility, compounding, alterations, many modifications of processes, hopefully not at the expense of patient safety, pharmacists involved in emergency response, as well as a number of items like end of life or hospice, PACs, or treatments. So with that being said, I do want to start out with a question for the panelists. What additional modifications or changes to processes have you had to make to ensure the safety of both your staff as well as patients? And some examples I know of are increased intensive care unit bed capacity, perhaps moving intravenous pumps outside of rooms to prevent going in and out of rooms, or providing central unit deliveries rather than focusing on patient bedside delivery. So those are just a couple examples. I want to turn it over to the panelists. How were your processes changed, and then how were they implemented?
Well, for our hospital, this kind of included the strict diversion and transport of patients with COVID-19 to different levels of hospitals on the basis of the severity of their symptoms. So for our severe COVID-19 patient, he was actually transferred to our internal medicine intensive care unit with the purpose and need of intubation. When it comes to the hospital wards, they were segregated to ensure appropriate patient care. Medication-wise, we basically follow one rule: whatever drug that goes in of the isolation room doesn't come out. So basically, we don't. It's not returned back to the pharmacy in concerns of contamination issues. Staff-wise, we get our temperature checked on a daily basis. And for face shields, safety goggles, and single-use medical masks, they've been regularly handed out to better protect our pharmacists when coming in close contact with these patients. Last but not least, for our outpatients, we actually set up this outdoor section where patients didn't have to, or who wanted to come refill their prescriptions, pick up their chronic medication, didn't have to physically walk into the hospital. And that was with the purpose of trying to decrease the potential of patients getting exposed to infection and limiting the unnecessary visits to the hospital.
Yes, in Spain, we did a lot of changes in all the drug use process in the hospital, and continuing with this outpatient May that you mentioned before. In Spain, specialty drugs are given in the hospital pharmacy. So we had to create and to advance some ideas that we had before, but we never concrete before, that telehealth pharmacy real fast implemented program. In days we had more advances than in the last few years. So we really implement a outpatient telehealth pharmacy program in most of the hospitals in Spain. It was not only our hospital, with review and clinical record. Then the pharmacy call the patient, document the interview and the safety and efficiency and all the documentation we need to do. We had a drug preparation quality control, and we include a lot of patient information in the medication we sent home. And then we had a lot of duty with the drug delivery, traceability, and monitoring patients back. So we really think this pandemic helped us a lot in implementing this program that we think is staying, is one of the things we are having from the pandemic. So now we are combining direct care with telehealth pharmacy program in the outpatient. But these patients are really happy with the service. We have done some surveys and they really are very proud of the pharmacies. We are super happy.
Thank you, Anna. Adenji Emmanuel, do you have any thoughts or comments on this question? I know we're working through connection with him, so hopefully he can chime in because I know he has plenty of great insights.
Okay, can you hear me now?
We can, thank you.
Okay, thank you very much. So we've had to make a lot of changes with regards to compounded duties. We enlarge our compounding responsibilities to provide and to produce large scale of hand sanitizers for the hospital community, the patients, and even for governmental agencies. We were able to produce the WHO grade of hand sanitizers that is able to serve the community around us. Also, we limited the access of patients into the pharmacy area, and every patient must wear their hand gloves or wear their face mask in order to reduce the possibility of transmission of infection to the pharmacy staff. Also, we created isolation centers for patients that are already confirmed as having the infection. And there we created a satellite pharmacy unit where we are able to provide all their medication needs, and we are able to give them counsel on the use of their medication. Thank you.
Thank you very much. Appreciate your insight and perspective on that question. What I'd like to move on to is another question in this area, and it's related to emergency preparedness and response, which clearly is an important role for pharmacists to play. So the question is, how are pharmacists involved in emergency response situations for COVID-19 patients in your country or your jurisdiction?
Okay, thank you very much for that question. In my country, with the advent of COVID-19 infection, a multidisciplinary team was set up, which include infectious disease physicians, anesthesiologists, nurses, pharmacists, cardiologists, and all other relevant healthcare providers. And with that, we are able to brainstorm and face the challenges or confront the challenges that come forward as patients come into the hospital with infections. Provide the medication, provide the cares, create isolation centers for them, and make all their medications available. However, in situations where the medications are not available in our facilities, we're able to liaise with pharmaceutical companies, with community pharmacies around, and source every medication for our patients. Thank you.
Thank you. Any other panelists have thoughts on that question?
Sure, John. In the United States, we have several government agencies, and what our government did is they pulled together a task force from those agencies, and included in the task force were pharmacists from our Centers for Disease Control, CDC, from the Food and Drug Administration, FDA, and from the Federal Emergency Management Association, or FEMA. And those pharmacists were part of a large task force that was looking at the preparation and response from the Strategic National Stockpile, ensuring adequate supply of drugs. So there were pharmacists represented at the national level making some of these decisions. And then in the individual hospital level, pharmacists are a very important part of the emergency preparedness just because of the medications that are needed to take care of COVID patients. We also had pharmacists involved in testing. In the United States, community pharmacies are the most easily accessible healthcare provider for patients. So some of our community pharmacies establish testing sites. And as we prepare for a vaccine, we expect that the pharmacies will be a very common place for patients to come and get vaccinated. So pharmacists have been involved at all levels of the emergency response here in the United States.
May or Anna, any final thoughts on that question before we move on?
Yes, it's nothing original. So I think pharmacy did a very good role in the crisis teams in the hospital, both in the general crisis and in the protocol crisis, and also in research. No, we have been talking something about the clinical trials and also the what has worked and what has failed and we have to change. So innovation in processes for next emergency situations. So I think involving pharmacists is very good for the institution, because drugs were used in all the institution, both in the hospital side and other hospitals, hotels that we have opened to keep patients when they were not very sick. So I think we have done a lot in the response. Yeah.
Okay, well, we want to be cognizant and thoughtful of time, and so I'm going to pass it on to Valerie to cover our last area of inquiry.
Thank you. So leadership, human resources, and training are all areas that have had to be adjusted very quickly during this pandemic. And so our first question for our panelists is, how are pharmacy staff being educated on COVID-19 and any new processes, policies, procedures, or guidelines? With everything changing so quickly, how is it possible to get everybody on board as soon as possible?
One of the first steps our hospital took was requiring all of our staff members to watch 5 videos, each around half an hour, and presented by clinicians that focused entirely on COVID-19, epidemiology, pathophysiology, and possible treatments later on. So when it came to the majority of our scheduled classes, in that case, we changed them all onto online learning courses. For our pharmacy department, we had weekly discussions and presentations on the latest journals and trials that have been since published. Also, I personally shared our experience in a case report format for treating mild to severe COVID-19 patients who have since all recovered. And if needed, I'd be more than happy to provide a few slides on the problems we kind of faced and how we resolved that when it came to COVID-19 patients, and the entire kind of before, during, and after processes if needed.
Thank you for sharing those thoughts. Anna, do you by any chance want to mention maybe how your pharmacy staff is being updated?
Yes, I think similar systems. We have a central repository where everybody has to check, and we have a lot of technology communication. But I want to highlight also the how to educate people in keeping safe and keep calm. I mean, at some points, this quick epidemic that came to our hospital, just in 10 days, everything changed. Roles changed. We had the education, and we are pharmacists, we are always into protocols and safety, so we are very used to checklists. But also for me, one of the fundamental parts that I learned in this pandemic is keeping people calm, because it's not only one day, but it's one day after another. So it's not like I've been living other disasters, like a train problem in Madrid or an aeroplane disaster, and it's only one point. But for me, the different thing here was like one crash every single day. So patients coming to the emergency room, we had to do a lot of discharge pack, discharge education. We have to keep population calm. All the outpatients we call, they always ask, how are you in the hospital? How's everything doing? I should do that or not? So I think this social part and has to be considered also as a very important part. And also considering in this crisis, we have more technology than ever, but the social distance, you know, for Spanish people that we are that social and that outdoors, was also a thing to rethink. So how to communicate in an order manner with this whole social distance, and we can't see face to face because of the mask, because of the distance we have to keep. So I think it was a real challenge.
Thank you for sharing. Yes, it's definitely good to remember that in this case, this disaster is more marathon and not necessarily a sprint, and that there are kind of ongoing needs that we have to address daily. Adenji Manuel, I see you have joined us via video. Were there insights that you wanted to provide about how your pharmacy staff is being educated?
Yeah, thank you very much. I'd like to make a contribution in that regard. Yeah, for the pharmacy service in my facility, we organize as a hospital, seminars and workshops were organized for the staff on how to address the challenge of COVID-19. Also for us, in order to minimize the possibility of infection, we have to minimize the number of patients, number of staff, pharmacists that are on duty each time. This we do by rotation. In a place whereby normally you have a large number of pharmacy on duty, we now have to spread it out each time, such that the contact is minimized for all our staff. Also, we had an isolation center where we created a satellite pharmacy unit to attend to all the patients that have been confirmed to be infected. Production of bulletins and other information materials are also made available within the hospital community for the members of staff on latest information on how to tackle the challenge of coronavirus. Thank you.
Thank you for sharing. Our next question concerns staff scheduling and whether or not there have been any modifications to limit contact between high numbers of staff members. So for example, utilization of remote staffing or creation of rotating shift teams. And Mike, I believe you had a perspective from ASHP that you were able to share.
Yes, in our surveys, we had asked about this, and 63% of respondents had increased remote work for non-patient care activities. So purchasing or review of event reports, but even for patient care activities, reviewing orders or engaging with patients, 60% of respondents had increased remote work. So keeping the pharmacists safe. But you also mentioned shift work, and we did hear reports of departments creating schedules where there were teams that would alternate, so that there were, if part of the pharmacy team became sick, they could quarantine and not expose other pharmacists. So there were some innovative staffing models that we learned about. One of the other things I mentioned is, not just remote work, which through the electronic health records is more and more possible, but also the telehealth. So even inpatients, providing telehealth to inpatients, it was a novel approach. Pharmacists were consulting with the different members of the team, with physicians, with nurses, and they were doing it through either video calls or Zoom meetings, but they were able to engage within the healthcare team remotely as well.
Great, thank you for sharing. Yes, telehealth pharmacy is definitely something that I feel multiple panelists have now brought up as a way in which to engage with patients and healthcare providers when they're not necessarily able to be face-to-face all the time for safety concerns. So we understand that it's about 10 o'clock a.m. Eastern time, which means that we've been here for about an hour. So if you're listening and you need to disconnect, totally understandable. The recording will be available so you can watch the end. But we will finish out this section, and then we'll try to do a quick question and answer session from those that have been submitted in the chat box. So in order to finish out this question, May or Adenji Manuel, did you have any comments about changing in staff scheduling at all?
When it came to pharmacy students, we did kind of make some adjustments. So they were not allowed to enter the isolation room, and not just for their safety, but also to kind of limit the waste of PPE, since N95 masks, hairnets, face shields, and gowns, foot eyewear protection. We're trying to conserve that for the nurses and physicians to use, since they're mainly the ones with the highest risk and having to come in close proximities within these confirmed COVID-19 patients. From what I know, we haven't gotten to the point where we have to recycle and sterilize and reuse these PPE. Even if it's during chart rounds in the ordinary wards, we have required that the student's preceptor has to be present at all times. So these are just a few adjustments we've made for our student safety.
Thank you. Yes, re-sterilization of PPE has definitely been something that I believe a lot of health systems here have discussed and or implemented. Adenji Manuel, did you have any comments about changings in staff scheduling before we wrap up this section?
Yeah, thank you very much. Well, we reschedule the duty for our staffs. We also limit the entry of patients directly into the pharmacy area. We created new rosters such that the duty is well spread out, and that has helped us to minimize the possible exposure of our staff to patients that are infected with the virus. Thank you.
Thank you for sharing. So we will go ahead and wrap up that section. I know that we had hoped to talk about learners, but the academic section of FIP had talked a lot about how to change current strategies to make sure that learners are still able to be incorporated during these interesting times. So with that, I will turn it back over to John, who's going to moderate our Q&A before we wrap up.
Thank you, Valerie. Just a reminder, if you do have a question, we would love to hear from you. And so use the question and answer feature on the Zoom technology, submit your question, and I will be monitoring those and I will ask the panel. We've had a handful of questions about specific treatment modalities and protocols, and I may not get into those specifically, but instead ask a question about telepharmacy and telehealth, because we've had a couple of really good questions about telepharmacy and telehealth. For those panelists, how has your country or your institution employed telehealth or telepharmacy to limit that direct interaction, but still provide optimum pharmacy care.
Yeah, thank you very much. In my hospital, for now, we use the social media to get information. We also reach our patients through the use of the telephone. Thank you.
Thank you for that. Anyone else using some type of remote modality or remote technology, maybe more so now than you would have before the pandemic?
Yes, we started also with the phone. I mean, in the emergency, you have to start with the tools you have really available, but we have become experts in Zoom. We are seeing this seminar as an example of that. But more at the hospital level, there is a safety platform now that based on Teams that we use. But really, you can start from the very basic with the telephone. And more than the tool that I think is important is setting the time. So for me, one thing I've learned is when calling the patients or when calling the doctors to set up an appointment. So the patient is really thinking on the pharmacist and really on the drug problems they have. Or same thing with the doctors, no? So we have learned to use the right tool, but also the right way.
I think for our hospital, there was always this option of the public just calling in and asking anything related to medication. So that's kind of what we've always been doing. We have seen a huge decline in the amount of visitors when it comes to our hospital. I would say around a 1/3 reduction, whether that be in clinics or people just coming in to pick up their chronic medication. But telephone is definitely the best way to kind of instantly answer any medication related questions the public has.
Mike, I'm curious, given that you work with a national association, have you heard anything from hospitals or health systems regarding telepharmacy and telehealth and how they may be expanding use of those types of technologies?
Yes, thanks, John. And you know, as I mentioned at the beginning of the pandemic, there was some reluctance or there was slower adoption from payers. So in the United States, we have private insurance, and we also have public insurance through our Medicare program. And there really was not a good framework for reimbursement of services offered through telehealth. So with the pandemic, a lot of those payers changed their policies, allowing providers to offer care to patients through the telephone, through electronic health records. A lot of the electronic health record platforms have mobile applications that can be used on smartphones. And as I mentioned, within the hospitals, use of Microsoft Teams or Zoom meetings for the interprofessional team to come together and collaborate. We saw increase in use of that. One thing that I haven't heard anyone mention yet, we saw a small increase in the use of technologies for monitoring the work that our technicians do. In the United States, our pharmacy technicians do preparation of sterile compounds or other medications before they're dispensed to a patient. And remote technologies can be used to monitor to make sure that those medications are prepared or dispensed accurately. And so because of the COVID pandemic, primarily because of PPE shortages and trying to limit the number of staff entering pharmacy clean rooms, we saw some increase in those technologies as well.
Thank you all, and thank you for those that continue to submit some questions. As we begin to wrap up, I think I'd be curious to know, and maybe many of our attendees would also be curious to know, if you could go back and do anything differently based on how your group or your institution has responded to the pandemic. Is there anything that you may do a little differently, knowing what you know now? I'd be curious to know.
I would like to make a comment on that.
Please.
Okay, can I go ahead?
Yes, please.
Okay, thank you very much. So, with the much we've learned from this webinar, I would like to go back to my facility and intensify efforts in communicating with my patients with the use of the other various telehealth facilities that are available. The use of Zoom, just like we are using this Zoom for this webinar, and all other facilities that are readily available. I would like to intensify efforts in that regard to communicate with patients that as a result of this condition, I may not be able to interface with them directly, but they need the assistance or the services of the pharmacies, and I will use all these telehealth facilities to communicate and reach them and meet them at their point of view. Thank you.
Thank you very much. Our other panelists, anything that you may have done differently, or anything maybe you've learned that you may not have expected?
John, one thing here in the United States that I think we learned, and I wish we had known earlier, was the distribution process of these drugs that are needed for ventilated patients. And by that I mean, typically when there's a shortage, we allocate drug to hospitals based on their historic use. So if a shortage occurs and a hospital orders normally 100 units in a week, they may get 70 units that week of whatever the product is. And that's evenly applied to all hospitals. Because of New York City being an epicenter, the allocations were being applied evenly across the country, where some hospitals had no COVID patients. They were still getting that 70% of whatever they ordered, as were New York City hospitals. So moving to a more dynamic allocation that was based on the number of COVID patients, the number of COVID patients in the intensive care unit, it took a few weeks for that process to get into place, and I think it created a lot of stress on the hospitals that were trying to prepare fentanyl infusions or neuromuscular blockers for their patients in the ICU. That's one of the key lessons that I think we know if we have another wave coming in the fall.
Thanks, Mike. May or Anna, any questions or things you'd like to share?
I learned also the things that we've been talking about, but also when you do a crisis plan, you have to do going back to normal work in the pharmacy. That's one thing I learned. I didn't expect that to be so hard. I told our hospital became a complete COVID-19 hospital, and it took us several days to learn how to go back. So I think when you have when we are facing and having all the protocols set for in case another crisis like that come, teaching nurses and doctors how to come back with the medication process and how to keep safe is one of the things I learned that have to be included.
I think, as previously mentioned, we had already kind of gained experience from past epidemics, SARS. So that's how this time around we were better and more effectively kind of controlling the entire situation and kind of knowing what to do at the right time. But definitely, I think as we continue to go on and this lockdown kind of, stores start to open and everything, and we might possibly see a second wave, it's something that we should be cautious of.
Well, thank you all. And I'm not sure I've learned it as a new item, but it reinforced how proud I am to be a pharmacist and how confident I am that there are people like you on this webinar and those of you around the world that are really placing patients first. And it's a great time to be a pharmacist. We need you all to continue the good work that you're doing, and I really appreciate you being on the program today. And there were a couple questions about specific treatment protocols, and I'm not ignoring you, but I think that might be a little outside of the scope of this program. There may be other FIP programs in the past I would refer you to, but we're also passing those questions on to our FIP colleagues and hope that perhaps in the future we can have some specific dialogue around protocols and treatment modalities. So thank you very much for that. As we wrap up today, I want to thank our panelists once more, my co-moderator, Valerie, as well. The recording of this episode will be made available on www.fip.org/coronavirus, a webpage that includes all of our COVID-19 resources. This is an opportunity for me to also invite you to join our new Facebook group, which is COVID-19 and Pharmacy, where you can join a global network of pharmacists discussing the pandemic. We are providing a 4-question survey that will pop up regarding this event. We request that you please give your feedback so that we may continue to improve our digital event offerings. We take your feedback seriously, and we will continue to offer programming that's relevant to you around the world. So with that, thank you very much for your attendance, and good day to you all.